Okay, so thanks, Rich. So what I thought I'd do is just talk to you about the work I'm doing in MS and Alzheimer's disease, and then leave the autism and the brain tumor collaborations with the David Ashley's guys off today's sort of roundup. So I'm a basic scientist. I've been at Duke for 19 years, so during which time I've accumulated a fair amount of MS and sundry neurological disease research. But what I thought I'd do is just sort of visually represent what's going on with the MS projects to date. So this is the DREAMS logo. So the Duke Center for Autoimmune and MS Disease Research. So I co-direct that with Chris Eckstein. And so we're going to be starting up our DREAMS research seminar series soon. But the longest research project that's been running in my lab is a collaboration with Mariana Garcia Blanco, who's down at UTMB in Texas, in Galveston. So when Mariana was still at Duke, we published the genetic association of IL-7R with multiple sclerosis. And since that first publication way back in 2007, we subsequently published 10 years later an epistatic interaction between not only IL-7R, but the gene that regulates IL-7R, DDX39B, to show that it's only in the context of both alleles do you have elevated threefold risk of developing MS. So it's one of the rare cases of epistatic interaction derived from a targeted gene approach. So we're looking at genetic association, and then followed up with the hypothesis that the gene that regulates the associated gene is also associated with MS. And since then, Mariano's postdoc has published the functional regulation of IL-7R splicing. So it's a very nice story. It's a longitudinal follow-up from an initial observation, and it's really quite interesting work. Another project that we're doing is working with the awesome infrastructure of the Murdoch study. So the Murdoch study, if you don't know about it, is a cross-sectional population study where there's around 12,500 participants from the Kannapolis and Cabarrus counties in North Carolina. So we leverage that infrastructure to collect MS patients, and the patients not only come from Kannapolis and Cabarrus counties, but they come more broadly across the state and also across the US. And in accordance with the sort of sample collection protocol from the Murdoch study, we've collected DNA, RNA, serum, and plasma, and urine, actually, I've left that off, from 975 MS patients. And because the Murdoch study has 12,500 controls, we can very, very quickly and ably match the MS cases to associated age, sex, race, etc. related controls. A number of years ago, we published a gene expression, genome-wide association, and tandem mass spec analysis of drug-free males to identify a signature of multiple sclerosis. And I should say that those biospecimens are actually going to be biobanked here at Duke. So they're being returned from the Murdoch study. And together with CSF that Andy Liu is collecting in collaboration with Chris Eckstein, we have a very sound and comprehensive MS bank that's available for faculty or trainees within the department to develop or pursue hypotheses. And we're talking with Elijah Lackey at the moment, who's a resident, or going to be a resident within the department. We've also administered a quality of life questionnaire to those patients. So Nila Marsha, under Suma Shah's guidance, has done a fantastic job of collating the quality of life information. So it's a combination of 26 different instruments. We had a meeting yesterday, and Nila's done a fantastic job with pursuing that. And within the 275, we've also got a longitudinal cohort of 22 primary progressive MS patients. Again, serum, plasma, DNA, and RNA. We collected 2 samples a year for 5 years. And James Duraputo, who was a med student in my lab, who has just matched to residency at now Yale Neurology, published a paper looking at predictors of disease progression by looking at neurofilament light and GFAP. We also have a collaboration with the Immune Tolerance Network. This is a study in which they were using atorvastatin to look at progression of or the development of lesions within clinically isolated syndrome patients. So we have a cohort of stable and active disease patients at baseline and then progression. And the ITN project is using PBMCs to try and identify a signature of differences in red blood cell, PBMC constituent change in different cell types within the cohort to see if we can identify a signature. And we've also done T-cell receptor profiling. So all this is single cell data. T-cell receptor profiling to see if we can identify any epitope-related immune receptor expression and relate that back to progression or activity of disease. And again, James is leading the way with that, even though he has finished his med school studies here at Duke. He's continuing to help with that. And the last project in MS I'll talk about is a collaboration with Eric Benner, who's a pediatric neonatologist here at Duke. Eric's been working on 20-hydroxycholesterol for a number of years, so it's a naturally occurring molecule. It occurs in breast milk. And what he's found in preclinical studies is that the administration of 20-HC actually improves outcomes in a sepsis model of pups that we're translating over into MS. And so we want to understand that the effects that 20-HC may have on decreasing inflammatory response in the context of cuprizone treatment, but also promoting remyelination here, just showing the corpus callosum. And we think the mechanism is by influencing the differentiation of neural stem cells down towards the OPCs and oligodendrocytes that facilitates that remyelination. And Eric and I are scientific co-founders of a company called TELUS Therapeutics, which is looking to translate that 20-HC finding into cerebral palsy. And then finally, MS disease research that I'm doing with Jerry, who is the director of the ADRC Brain Bank, and Diane Cruz is the director of the Neuropsych Brain Bank, both here at Duke, obviously. And in this approach, we're pursuing a hypothesis in which we believe that you can take 4 different regions from an Alzheimer's disease decedent to plot the trajectory of disease development. So from the entorhinal, the occipitotemporal, the dorsolateral PFC, and the striate. And we're using those 4 different brain regions and technology that I spoke about in the research summary probably a couple of months ago now, where we're using spatial approaches to understand the expression of genes in the context of different regions within the brain. So here, the plaques are defined in blue and the periplaque regions in red, so we can identify differential gene expression in plaques versus periplaque. We can start looking at the cytoarchitecture, so we've defined the 6 lamina of the gray matter and look between samples. We can add single cell data. So here is a study that was published in 2020 looking at microglia specifically in the context of the Alzheimer's brain, map that data back to our single cell data and look to see whether it's, we see signatures of expression of, in this case, it's microglia in the context of our own tissue. And then this approach will be translated into in situ transcriptomics, which I talk about in the research follow-up. So whereas each dot is effectively a 55 micron field in the context of the tissue, here, each spot is a transcript and each blob, if you like, is a cell. So it's much, much higher resolution. So we'll be able to see cell neighborhood interactions. I'm very pleased to say that Jerry, Diane, and I were funded by the ADRC recently. So it's a $100,000 grant to pursue this in more than just these pilot projects. And I just want to finish by saying we have started the Neurology Research in Progress meetings. It's on the 3rd Monday. It's in 301 Bryan from 5:30 to 6:30. So that's for any research that's being presented or developed within the department, and they're 30-minute talks, talk about grants, talk about paper development, or just ideas around research. And that's it. So if you've got questions, please reach out.
Great. All right. Today's grand round speaker is Catherine Taylor, and Sujay will do the introduction.
Thanks, Rich. I have the distinct honor of presenting Dr. Catherine Taylor for Grand Rounds today. Dr. Taylor graduated from Furman University, where she studied neuroscience as an undergrad. She went to Campbell for her medical school training. And then she joined us at Duke 5 years ago, where she started her pediatrics residency, followed by child neurology fellowship training. Even during her time with us, She served as an adjunct faculty member back at Campbell, where she really went back and lectured quite a bit about child neurology. And so I attribute the fact that we've had a steady stream of child neurology hopefuls from Campbell to Dr. Taylor's work. She's had a productive time here at Duke. She's participated in the medical education and leadership track, made lots of research contributions. She's had a neuroimmunology interest, and that culminated in publishing a chapter in a rheumatology text about autoimmune brain disorders. She served as our education chief this year. She greatly improved our didactic structure despite the challenges of virtual learning. Over the 6 years that I've known her, because I've known her since medical school, she's turned into an amazing, astute, compassionate, really thoughtful physician. And we are thankful she's not going too far away. She's going to join the faculty at MUSC next year. And so they are very lucky to have her. Her talk this morning is entitled Childhood Disintegrative Disorder. So Dr. Taylor, I'll turn it over to you.
Thank you so much, Sujay. Good morning, everybody. So as Sujay said, the talk today will be on childhood disintegrative disorder. I'm just going to see if I can get this to work so you can see my slides. Can everyone see these okay?
Yep.
Great. So we're going to start with an introduction to childhood disintegrative disorder. I'll then review the previously accepted diagnostic criteria and related discussion, and then describe several other conditions with regressive phenotypes and which characteristics are shared with CDD, followed by a review of several cases seen here in the multidisciplinary pediatric autoimmune brain disease clinic, with a particular focus on the symptomatology. I'll then discuss the ongoing diagnostic and treatment challenges with these neuropsychiatric illnesses and what we've gleaned from the cases so far, and then create time for some more discussion and questions. So over 100 years ago, an Austrian educator and clinician named Thomas Heller described the sudden and severe loss of cognitive and adaptive function in previously normally developing children. He referred to this phenomenon as dementia infantilis and described 6 cases he had seen in his clinic. And these children had developed normally until the age of 3 or 4 years old, and then had dramatic adaptive losses, ending up with little or no language and strange behaviors and stereotypies. This clinical diagnosis has since been known by several names, including dementia infantilis, Heller syndrome, disintegrative psychosis, and more recently, childhood disintegrative disorder. The etiology of this remains undetermined, and metabolic, primary psychiatric, genetic, and immune-mediated causes have all been postulated. The connotation here with childhood disintegrative disorder is appropriately frightening. It entails sudden and significant neurodevelopmental regression in children with previously normal development through at least 2 years of life, with sudden loss of developmental and adaptive skills that occurs quickly, and there's collapse across multiple neuropsychiatric domains. So cognition, language, development of seizures, psychiatric symptoms, disordered movement, and sleep. And this occurs within days to weeks of decline onset. These children exhibit restrictive, repetitive, and stereotype patterns of behavior and interest as well. And those last qualifications may remind you of aspects of the more current criteria for autism spectrum disorder, which is a group of neurodevelopmental abnormalities beginning early in childhood and characterized by issues in social communication along with behavioral problems. I won't be going through each aspect of the criteria, but wanted to provide a visual illustration to summarize the current diagnostic criteria for ASD. One substantial modification between the DSM-4 and the DSM-5 was the consolidation of various subtypes of pervasive developmental disorder into the diagnosis of ASD. And that change was made for many reasons, including literature that was felt to demonstrate that the diagnosis of these different subtypes, particularly Asperger's, were not as reliable across clinicians. The symptoms are now represented in a 2-domain model with social communication deficits in a second category with restrictive and repetitive interest in behaviors. There's additional modifiers that were also set that I've included in the box outlined here in blue, and an attempt to recognize that the clinical heterogeneity among children meeting criteria for ASD definitely exist. And there's efforts there to acknowledge that this is a behavioral diagnosis with varied etiologies. These specifications include the presence of language or intellectual impairment, and then association with known medical or genetic conditions. So CDD was incorporated into the autism spectrum disorder in the DSM-5. It's no longer considered in this manual as a distinct diagnostic category. So this change continues to be discussed as there are two main camps of thought regarding this transition. The committee responsible for reworking the criteria for autism spectrum disorder stated in their defense of the decision that this entity was not separate enough to sustain its own diagnosis, and that children previously meeting the DSM-4 criteria for CDD now fit well into the new diagnostic criteria for autism. If you think about the word spectrum and then imagine trying to responsibly create distinctions between those contents, you can appreciate the challenge they were up against. Certainly, it does make some sense to consider autism spectrum disorder and CDD together in a lot of ways, given the similar behavioral traits that children with CDD exhibit following the regression to children with other phenotypes within the autism spectrum. But does this merge come at a high price? The relative rarity and paucity of the published clinical information regarding CDD were referenced as justifications for this being subsumed, but this combination could potentially contribute to those very issues. Without an at least subdivided diagnostic category, there's concern that clinicians would be less aware of the phenomenon and less likely to bring these cases up to the attention of other clinicians and researchers, potentially creating a self-fulfilling prophecy. For over 100 years, clinicians have recognized that there's something distinct about this phenomenon, and they feel that there may be overlapping presentations here and ultimately similar phenotypes, and that the initial course and potentially underlying pathology are distinct. So to argue for the nosologic validity of CDD, we can highlight the differentiating features from autism, including autism spectrum disorder with regression. One of the primary distinctions have been the duration of the previously normal neurodevelopment and the timeline of that regression between the two conditions. A meta-analysis of 85 studies demonstrated that about 1/3 of patients with autism spectrum disorder demonstrate regression, with an average onset at 18 months. So the reported range for this in the literature seems to be anywhere from 12 to 30 months. With childhood disintegrative disorder, the prior definition required that normal development through the 2 years of age, and typically regression occurred after 4 years of age or older and could happen through school age years as well, with a mean age of onset around 3 years and 2 months. A more recent systematic review found that across 4 epidemiologic studies, 100% of the CDD patients had reached all their age-appropriate developmental milestones before the onset of symptoms. And in contrast, only 10% of control ASD cases assessed and 14% of ASD cases with regression had reached all of their age-appropriate developmental milestones before the onset of developmental plateau or regression. Other distinctions from ASD that are reported in the literature include higher rates of eye contact, substantial fearfulness and hallucinations at onset, and higher rates of epilepsy and mutism. This table is from that systematic review that included 20 studies with 96 participants with CDD. They reviewed the clinical characteristics and paraclinical markers compared with patients diagnosed with ASD and ASD with regression. And this includes several of the core symptoms that were included in the DSM-4 criteria. So in CDD, previously developmentally appropriate children lose their speech in a matter of days to weeks and exhibit new and disabling function in other areas like bowel and bladder control, motor skills, cognitive and adaptive function. So this type of regression is not confined to language and social abilities. Symptom onset occurred over 2 or fewer months in 16 out of 40 participants with CDD versus 1 in 21 participants with ASD. And then diagnostic differentiation reports have indicated that in regards to the natural course of CDD, most patients experience some overall improvement or no further change in the disorder severity over the course of follow-up, and they may exhibit multiple episodes of regression. Children with childhood disintegrative disorder ultimately have lower IQ scores, more prominent mental health symptoms, higher incidence of epilepsy, and generally poorer overall prognosis compared with children with autism spectrum disorder. We can appreciate that there are similarities in the clinical presentation of CDD with other entities in addition to autism, that regression is in no way unique to autism. There is precedent here in patient populations with otherwise normal development, and also others that include children with previously atypical neurodevelopment, like Down syndrome disintegrative disorder, which is characterized by the loss of previously acquired adaptive, cognitive, and social function with new autistic characteristics in people with Down syndrome, and usually presents in adolescence or early adulthood. Rett syndrome is no longer consolidated under ASD and primarily affects young girls and often caused by a mutation in the MECP2 gene. While subtle findings might be present before age 2 to 4, it's marked by a typically rapid decline in speech, fine motor skills, and coordination around that age. There's also a subtype of Phelan-McDermid syndrome with point mutations in SHANK3 gene that's also being studied here at Duke, and characterized by mild, moderate developmental delay until around the age of puberty, where some patients with this genotype experience subacute onset of significant further neurologic regression, psychosis, sleep mood disorders, and with loss of self-care, bowel or bladder issues, and obsessive compulsive behaviors. The behavioral phenotypes of autistic regression also have some overlap with presentations of Landau-Kleffner syndrome and continuous spike wave during slow wave sleep. There are other neurodegenerative diseases that certainly have regression, childhood leukodystrophy and iron accumulation, but these typically have additional neurologic features, but with similar apparent natural course. Immune-mediated brain disease may also be included here. Some of the clinical features of childhood disintegrative disorder that distinguish this condition from ASD are actually shared with the clinical presentation, the onset of autoimmune encephalitis. The criteria for pediatric autoimmune encephalitis include subacute onset, so less than or equal to 3 months, of neurologic and psychiatric symptoms in a previously healthy child affecting at least 2 different domains of neurologic function. A diagnosis of AE requires paraclinical marker of inflammation from the CSF, on neuroimaging, brain biopsy, or detection of an associated antibody. Those meeting criteria for AE without an identified autoantibody are classified as having probable seronegative AE. And the proposed pediatric classification criteria for AE guides providers through the workup and diagnosis. And once that workup is complete, the current recommendations are to initiate treatment with first-line therapy for those meeting possible AE criteria, similar to adult criteria. And while not jumping to assume one common underlying cause for these conditions, CDD and AE share some aspects in clinical presentation, and there's comparability in the natural courses of these diseases. So what might be gleaned from this comparison? CDD is still poorly understood, and the etiology remains unclear. Immune-mediated causes have been considered. Other treatments for CDD are not well established, and given the growing experience with antibody-negative AE and some of the shared psychiatric and regressive features in these conditions, immunotherapy has been previously trialed and reported in case studies citing improved behavior, motor, and language function, but the reports are limited overall. We hypothesize that in rare circumstances, this constellation of presenting symptoms may be similar to that of seronegative autoimmune encephalitis, and that features of this presentation may elucidate a small subpopulation of patients with CDD who may respond to immunotherapy. There are several collected cases of children identified in the Duke Pediatric Autoimmune Brain Disease Clinic with presentations consistent with CDD or ASD, with marked subacute regression and overlap with seronegative autoimmune encephalitis who received first and second line immunotherapy. By describing the clinical features of these patients and studying their course, we hope to help identify features of the clinical presentation that may point us towards subpopulations that might benefit from immunomodulation. So the set of inclusion criteria was comprised of acute to subacute onset, so less than 4 weeks, onset of profound loss of language, including an inability to express their needs and wants, minimal receptive language, loss of awareness of their surroundings or interactions with others, and a loss of independent play, loss of basic age-appropriate adaptive functions, including feeding themselves, toileting, and dressing, and treatment with immunotherapy for at least 6 months. So these are 3 exemplar cases from our cohort, which I'll be going back to at various points of the presentation. The first case, CE, was a previously healthy and developmentally appropriate 5.5-year-old boy who liked playing with his friends and going to school. He had a febrile illness with upper respiratory symptoms, and 8 days later developed sudden onset of odd behaviors, including inspection and refusal of food, forgetting how to play with his toys, pacing and swinging on doors. He had hypersomnia, night terrors, new hand flapping movements, significant cognitive decline, including losing the ability to engage in all of his school, visual hallucinations with new fears, including significant terror of his reflection in the mirror, obsessions over food contamination, impulsive behavior, jumping in the family pool with all of his clothes on, no apparent planning, and then seeming to forget how to swim, requiring parents to come in and help him. He developed incontinence, self-injurious behavior, spitting. He was unable to state his own name or identify his parents. He had loss of motor skills and complete refusal of oral intake for 2 to 3 days, spitting out all his food and forcefully wiping tongue with towel. He initially had substantial vocabulary restriction and then slurred speech for about 4 months after onset. He became completely nonverbal and unable to perform any ADLs. His workup, including MRI, prolonged EEG, lumbar puncture, serum and CSF autoimmune panels and inflammatory markers were all unrevealing. The second patient here, another previously healthy 5-year-old with subacute onset of symptoms following strep throat, had a very similar presentation and constellation of symptoms as our first patient. And then the third patient here had previously atypical development with a prior diagnosis of speech delay and concern for pervasive developmental disorder, who had a sudden loss of skills crossing several neurodevelopmental domains shortly following a febrile or flu-like illness. This patient was previously doing well in middle school and on the cross-country team. He developed insomnia going as long as 36-hour stretches, often without sleep, new stereotypies, visual hallucinations and delusions, new self-injurious behavior resulting in significant injury to his head. He would be found lost in his school hallways. He lost the ability to write completely and perform basic self-care tasks like brushing his teeth, bathing, toileting, or being able to use utensils, only being able to do that if his parents put food on the fork for him. He was previously reading and doing well in math and then had to withdraw. Shortly following onset, he called out to his parents in the middle of the night, "Mom, Dad, am I all right?" And then after did not speak again. So our cohort has a bimodal distribution of age onset, with the subgroup of typically developing patients with classical CDD with a mean age of onset of 5.5 years with a range of 3 to 8 years, and all were males. There's another subgroup with atypical development, so patients 6, 7, and 8 here, with a mean onset of 12.3 years with 2 females and 1 male. 6 cases reported a prodromal illness a week or so before disease onset, and 2 reported a significant psychosocial stressor preceding regression. This table is a summary of the neurodevelopmental symptoms seen. One notable distinction here from our cohort and other CDD literature is the absence of seizures, which is likely given that the presence of seizures here would have met criteria for an alternate diagnosis and exclusion from this cohort. 6 out of the 8 patients had complete loss of speech. We saw marked sleep disturbances, not sleeping up for several days, or continuous time with less than 4 hours of sleep at night, significant cognitive decline, incontinence, all with previously achieved bowel or bladder control, impaired motor skills, particularly in regards to fine motor skills like handwriting and using utensils. There was also pervasive presence of new substantially worsening restrictive and repetitive behaviors and interests, and new motor stereotypies. In terms of psychiatric symptoms, hallucinations were clearly present in 6 patients, typically visual hallucinations. Compulsions and obsessive behaviors were present in 6 out of 8 patients, and fear and anxiety at onset was clearly present in 5 out of the 8 patients. Aggression and agitation was a pervasive feature, and pacing was predominantly noted symptom. So steroids and IVIG were given to all 8 patients. In some cases, there was escalation to steroid and IVIG sparing agents. Additional immunomodulating treatments used most frequently were rituximab, Cellcept, and Toci. So we recognized 3 patterns of response to treatment. Pattern 1, a sustained building definitive response and return of most adaptive functional skills, although without complete recovery of the cognitive or executive function they experienced before. Pattern 2, with an initial positive response that plateaus with ongoing and waxing and waning severity of their symptoms, with marked differences from their prior baseline. And pattern 3, no clear response to treatment with some undulation of their course, but no clearly sustained improvement past their basal level of function. So going back to the 3 exemplar cases we discussed, patient 1 is the 5-year-old male I first described who after initial IV steroids and IVIG showed building response with improved adaptive function, decreased disruptive behavior, still minimal language over 6 to 9 months without apparent cognitive gains. Mycophenolate was then added without further improvement, and then TOSI was added with notable return of some language skills, play, reciprocal interaction, building over another 8 to 9 months, and seemed to then largely plateau, with the exception of some improvement in cognitive abilities. Patient 5, the other previously healthy 5-year-old with subacute regression that we talked about, demonstrated subtle improvement in some affected domains. And then patient 8 is an example of the third pattern, the 13-year-old with the previously atypical neurodevelopment, where there was little to no discernible improvement after a significant regression. So one child with previously abnormal neurodevelopment had no clear response to immunomodulation. Another 4 children had less robust response with waxing and waning symptoms, but improvement from their nadir. For these patients who exhibited this intermediate pattern, we recognize that this response is difficult to interpret, as this may lend towards the natural course of CDD. And while none of the children in this cohort met the current diagnostic criteria that's now available for probable seronegative AE, given the absence of pertinent periclinical markers, 3 children demonstrated marked response to immunomodulation. All 3 of these children were previously healthy and developmentally appropriate males between the ages of 4 and 8. And while this is largely a descriptive effort, this response is at least provocative enough to warrant additional investigation and consideration of next steps in the study, particularly given the severity and the disabling nature of this disease. So we have 3 major points gleaned from the review of the relevant literature, our clinical experience, and the information in this cohort. The first point being that in the majority of cases, there's sufficient presentation overlap between CDD and autoimmune encephalitis to warrant a thorough workup. Most of you are obviously quite familiar with the workup for autoimmune encephalitis. It includes a brain MRI with and without contrast, lumbar puncture, EEG, preferably prolonged to capture adequate sleep, and CSF and serum autoantibodies testing. Additionally, vascular imaging, ophthalmologic evaluation, and neuropsychiatric testing may be included. And we recommend that patients with CDD receive this same workup, given the subacute onset of regression encompassing multiple domains. The role for genetic investigation cannot be understated and can lead to a better understanding of CDD, autism, and autoimmune encephalitis as we work to better differentiate these phenotypes. Both chromosomal microarray and whole exome sequencing would be warranted in these rare cases. 2 of the boys in this cohort with relatively poor response to immunomodulation had abnormal CMA results. These abnormalities had some potential connection to ASD, but it was not well established. It's also important that when we interpret these results to recall the rarity of CDD. So for every 103 cases of autism, there may be 1 case of CDD. And this could contribute to the limited information that is published, but not negate the possibility of a genetic predisposing factor. And finally, we are in search for improved objective measures and most appropriate biomarkers. To best address this information, we need objective measures. And this is a pervasive challenge in both the adult and pediatric neuropsychiatric conditions. Currently, there's a heavy reliance on retrospective studies and caregiver reports of symptoms, which limits validity. And with a lack of objective measures, not only is it difficult to establish the most appropriate diagnosis, but it also limits the ability to adequately assess treatment response, which is no longer a criteria for pediatric seronegative autoimmune encephalitis, given similar limitations. And with CDD specifically, because of the rarity, little is currently known about the natural course of the disease, making controlled cohorts with longer duration especially vital. It's also important to include an attempt to account for confounding variables like ancillary therapies these patients received and genetic and environmental factors. So this is patient E. This is the first case that we discussed with permission of his family to show these, just to kind of give you guys an illustration. So he can now talk about his favorite books. He can speak in some complete sentences. You can see he's doing some simple math and able to go on vacations with his family. He's the little one on the far left. He will answer some questions and has some spontaneous speech with members of his family, particularly his brother. He can again perform some functions of daily living like eating and toileting independently. He still experiences waxing and waning degrees of anxiety and just again, starting to learn sight words and early math, which is below the level of academic performance prior to the onset of his regression. So this is a devastating condition and requires further investigational effort. Overall, we need further study to reveal the genetic and pathophysiologic mechanisms involved in late onset regression attributed to CDD and developing optimized treatments and behavioral therapies that may improve outcomes in this challenging population. So I'd like to take a minute to thank Dr. Carolyn Pizzoli. I don't know how to thank you enough for your mentorship. You've held us together, and seeing your presence and wisdom that you demonstrate to your team and your patients has impacted me tremendously. I'm so grateful for you. Dr. Makati, thank you for your leadership. Dr. Consagra for your advocacy. Dr. Zafar, Dr. Lemon, so many others for your guidance. We have a fantastic team, and I'm so grateful to have been a part of it. Our clinical team, April, Maggie, Sue, and Pam, without these women, our outpatient world would potentially screech to a halt. And to my co-fellows, Matt, Lauren, and Kaylee, I'm so appreciative of you and very proud to have been a part of the team with you guys. It has been my honor to work with you all, and I will miss everyone in this department very gratefully and thankful for my, very greatly and am thankful for my time here.
Thank you, Catherine. That was wonderful and very, very sad. How many of these cases are there? And by the way, anyone with a question, just put your name or your question in the chat and we'll get to you. In the country, would you say?
So I don't have that information. I do know that the prevalence there is about 2 for every 100,000. But since the DSM-4 criteria and with that being subsumed into ASD, there has been kind of limited literature out there to give us a good idea of that exact number.
And how reliable is the description of febrile illnesses and things of that sort before the onset?
So I think with any of these, there is always certainly some potential bias with kind of hindsight, especially depending on when we came across the cases. But in this cohort, they were all described in the initial reports within about, I believe, 1 or 2 weeks from symptom onset. Most of them including documented fevers.
Marvin Rosier and Jim Burke kind of have the same question. Marvin, do you want to ask it? Jim, why don't you take it over? Marvin might be having some issues.
Yeah, that's a great presentation. So have there been autopsy findings? And over time, do you see changes in MRI atrophy, any kind of enhancement?
I'm not aware of any postmortem studies that we have to answer that question. And then these children, we did not see any abnormal MRI changes that changed over time or after treatment response, and that wasn't really seen in the review of the literature either.
Lee Hartzell? I'll read it. Lee says, how might you differentiate this from Hashimoto's? Does Hashimoto's exist anymore, or is it just an autoimmune encephalitis?
That's a really good question. I thought this might come up. I think that, I mean, we do still often call it Hashimoto's encephalopathy. There's a growing trend towards trying to have better description here, moving towards this, steroid responsive encephalopathy associated with autoimmune thyroiditis. I think it's an example of, kind of how some of these catch-all phrases we can use earlier may actually contribute to kind of this false imagination of these phenotypes. And for this, you have to have either anti-thyroglobulin or anti-paradoxic antibodies present with high titer positivity. Those were checked in this cohort and not present. And then additionally, seizures is one of the most common reported phenomenon, at least in children here, and we did not see that in any of our patients. But most importantly, the antibody positivity.
I think it's still a great question and point, though, because of that high antibody prevalence in the general population, and while not in our cohort, in general in CDD, there is a higher incidence of seizure, up to 30%. Number one, does that mean some of these kids really might have whatever Hashimoto's encephalopathy is or was? Or number two, are these criteria, because of the antibody prevalence and CDD's existence as an alternate diagnosis, may be too loose? But this is the one that gets us into trouble the most, when we have these kids who don't squarely have additional neurologic features, squarely have MRI or other LP findings, but you just get that one serum antibody and it makes you wonder, is this CDD or is this really Hashimoto's? It gets challenging.
And Duke doesn't do titers, right? They just give you positive or negative. To get the titers, I think you have to send it to Mayo.
I feel like back in the day, the lab would tell us some, but not like report them out or kind of give you gradations. I don't know if that's changed. I haven't asked for a while, but you're right. It's the literature says, oh, well, you do this, but it's kind of hard to get that done in a clinical laboratory sometimes.
Heather Van Matter says, true, have to send to Mayo. Well, Catherine, that was a great presentation, a really challenging set of patients. Oh my God. And thank you for doing this, and best of luck to you in all your future endeavors. And thank you for your, how many years at Duke has it been?
5.
For 5, giving us 5 great years. Yeah. Thank you so much. Bye, everybody.